Thank you all for coming out to another HRG weekly webinar. We hope that you're all enjoying your summers wherever you are. Hopefully there's great weather, and we are so happy that you're taking the time to join us in these uncharted times. Each week on Wednesday mornings, HRG is committed to providing industry updates and tips and tricks that you can leverage right away. As usual, before we get started, just a couple housekeeping items. To make sure that we honor the 30 minutes that we've allotted today, we will answer any questions that come up in an answer sheet that will be sent out later this afternoon with the remainder of the webinar resources, including the slides and the webinar recording. Since the beginning of this pandemic, we have seen a huge increase in telehealth, and with that, so many more complications for coding and billing of these new services. This morning, we have HRG Executive Director of HIM Coding, Teresa Tate, joining us to discuss avoiding telehealth documentation woes. Go ahead and take it away, Teresa.
Thank you so much, Taylor. I appreciate the opportunity. Just a quick little introduction of myself. Again, my name is Teresa Tate, and I've been working with HRG for almost 12 years now. And before that, I was basically a production coder. And so I'm very familiar with the ever-changing needs of the industry. But I think we are in uncharted times, as Taylor mentioned, with the COVID and pandemic. We've had some code changes that are happening very rapidly. And so it's been a little bit hard to keep up, and especially when we have the vendor perspective, we're not only keeping up with our local state and Medicaid and commercial payers, but all across the United States with the different Medicare contractors. So it is definitely a challenge, and we feel your pain. So one of the things that we wanted to do was, as we're going through the documentation and we're writing this wave of these coding changes, we just wanted to share some of the items that we've identified along the way that have been challenging as far as documentation. And I know that on your end and for all organizations, it has just been such a challenge to keep up with all of the changes that are happening and communicating that both to your provider so that your documentation can be up to par and meeting those requirements, but also for your billing teams, your coding teams, and making sure that you're keeping track of the dates of when these changes happened. And so it can be very confusing. So this is just a very brief overview of some of the more common documentation challenges. And I'll go ahead and move to the next slide. I do want to say that I'm going to put a little caveat in here that when you hear the terms telemedicine and telehealth, oftentimes they're interchanged. They're actually different types of services, whereas telemedicine is based on very specific HIPAA-compliant regulations, and then telehealth is kind of encompassing those guidelines, but also some of those new temporary policies and options that may not be HIPAA compliant during the COVID crisis, but they're acceptable right now. And as you see in the slides as we move forward, some of these fixes are temporary. And so we're just going to, again, pay attention to the dates, the effective dates, and when those get rescinded, and if and when they get rescinded. But I fully anticipate that because we're using these telehealth codes, that there could be some long-term changes because they're identifying we can do a lot of these services via telehealth. And so there's a lot of benefits to that, especially when you have homebound patients, et cetera, or you don't want to risk, obviously, contamination. So along those lines, many of the state and federal payers have very specific guidelines to how they want these services coded. It's really hard to keep track of all of them. You have your big ones, but even then, Medicare might have one Medicare administrator contractor like Novitas might want it differently than Noridian or First Coast. So I would highly recommend that you go out and avail yourself of all of the published information that they are sharing and make sure that you subscribe to their updates, especially with regards to COVID and telehealth. One of the things that we have done internally is tend to be a little bit more on the conservative side in that we try to find the most strict guidelines by Medicaid mostly, because Medicare has a little bit more flexibility in some of their items, or their requirements, but Medicaid, as you go from state to state and look at the different policies, some of them can be quite strict. And so what we did in an effort to be the most comprehensive with our training for our coders is to say, here's the strictest rules we can find, and let's go ahead and apply those when we're looking at the documentation. And then that way, if you have a patient that changes insurance, maybe they didn't have insurance and they're now eligible for Medicaid, or maybe they've lost their job and they are now eligible for Medicaid, that documentation should stand up if you're following the stringent guidelines. So The other caveat that I wanted to say is that the information that's provided during this webinar, it cannot be considered official coding advice because there are just too many ifs and thens dependent upon what type of service you're providing, what Medicare or Medicaid contractor you're using, what contracts you have with your individual payers. There's changes that are happening in real time. So this information is very generic based on what we've been finding in documentation. And so it may not be consistent with your payer's requirements. So just please do kind of take it with a grain of salt and use this as basically an overview. So as you can tell, it can be a little bit overwhelming, all of the changes that are happening. There have been new approaches to patient care to include these audio and or visual technology options that and modalities that were used for some resources, but not widespread. Many of the codes were not even considered payable outside of certain circumstances. And an example that I could use would be our experience with working with Alaska Tribal Health. They have what's called a community health aid program, whereby they have members of the tribe go through actual training, and they have a manual, and they work through the process of learning how to become a provider. And the manual walks them through these steps. But they're out in rural, remote locations where their beneficiaries, the tribal members, can't always come into the bigger cities like Anchorage or Fairbanks and see the doctors. So they have a scarcity in their local villages for medical care. And so they did a lot of the telehealth through asynchronous video where you could store it, forward it, and share it with the providers at a distant site and be able to basically have a face-to-face visit, look at an echocardiogram. So some of this was already in place with some of these programs, but they were very specific. Most of the time, if you pick up the phone and you call the patient to give them a lab result or things like that, that's a non-payable service. So telehealth was not the mainstream. So because of the COVID pandemic, it has become a lot more mainstream so that we can prevent the spread and due to the stay-at-home initiatives that are put in place. So again, many of these new telehealth options, they didn't have a lot of rules and regulations that applied to mass patient care. They were very isolated in how we were using them. And as I mentioned before, some of these fixes that they've put in place to use these telehealth codes were temporary. So we had to approach this. How do we give our clients and our providers the most concise, effective information that should cover them no matter what insurance is being billed? And that's where I go back to using the strictest, most stringent guidelines that we could find. And if we are giving them those bulleted items to make sure that they're including in their documentation, we kind of feel like that's a really solid foundation to build from and should cover them regardless of which insurance they follow. And so some of the common forms of telehealth, as you can see, are you have your audio and video technologies. One thing that came about was the Zoom for Healthcare, which is considered HIPAA compliant, by the way. So, and it many times is free to providers. You have your audio only, which is your telephone or telephone apps, and again, your computer apps, approved social media apps. And so while I want to call out that the Zoom for Healthcare would be considered compliant, the regular Zoom meeting app would not meet those, would be considered non-HIPAA compliant. It doesn't necessarily mean that you can't use it. It just means that there's different consent that needs to happen with the patient. Also, some options are Skype or FaceTime would not be considered HIPAA compliant. But again, so long as you're communicating with the patient and getting that consent, there are options available to use those. With regards to the computer apps and some of the approved social media apps, there's WhatsApp, Facebook Messenger video chat, some Google Hangouts video that are approved, but not approved would be Facebook Live or TikTok. So we just have to make sure that you're looking at what the approved list is before utilizing those and sharing private health information over those apps with the patient. And again, as always, we've had the email, the texting. There are patient portals that have come into play recently, and so I know that I use patient portals quite a bit. Virtual check-ins, teledocs, things like that, that were actually starting to come into play before COVID happened, and e-consults. So just noting that when we're delivering these healthcare services, that when we're talking about telehealth, we're talking about that audio or audio-video combination, that technology that allows that real-time interaction between the patient and provider so that they can basically assess, diagnose, treat, refer to another provider if needed, and all of that is basically in lieu of that face-to-face visit. just wanted to give you, I've talked about some of those bulleted items that kind of help us make sure that we're following those strictest rules. And this is off of the Washington State Medicaid site. And so they did a very nice job of documenting the examples of things that they're looking for in the telehealth documentation. And as you can see above, they've talked about using Zoom and the asynchronous and synchronous audio-visual, but being very specific about what modality you're using. So just a quick review of these. We're going to touch on these because, as you can see, if you have bulleted items, then you probably have documentation issues that go along with that. So I don't want to spend a whole lot of time going over each of the individual bullets, but I do want to be able to share this with you because this is a good way to potentially start a template for your providers or share this with your coding team and look at the definition of the telehealth modality or service that you're providing and then comparing it, is this information documented? And if not, how do we get that into the system so that we can follow the compliance for even the most strict of our payers? And so just a quick note that when there is an audio or an audio video only, for obvious reasons, you are not laying hands on the patient, you are not doing your own exam, but the patient can potentially utilize certain tools to be able to give you basic vitals. They can give you height, they can give you weight. Sometimes they have an at-home blood pressure cuff monitor that they can look at and potentially show you over the camera. You can look at somebody's skin, or they can look into the camera and maybe pull down their eyelid a little bit and look in their eye. So there are certain things that you can do that are visual only that you don't necessarily have to lay hands on the patient. So there are some forms of exam that can happen. You can look at somebody and see what their range of motion is, but you cannot palpate their abdomen to see where they're tender. So you're reliant upon the patient to give you some of that data. So what I would say is document the same as you would as if the patient was in the office as much as you can. Do as much of the exam, ask the questions. If you have the video capability, be able to share them or ask the questions about the range of motion, those types of things. So do your best to fulfill the key elements, your history, your exam, and your medical decision making as you normally would for those visits where you're assessing and treating an issue. And so just make sure that when you are documenting it, that if it's video, it's being able to be recorded, then you could be able to see that. But if it's audio only, whatever those items that you are, is just make sure that you're documenting that you're getting this information from the patient's perspective when you're doing that. So we'll move on to a few of the items that we've come across where Medicare guidance has differed from state Medicaid programs pretty significantly. And even amongst the different MACs, the Medicare Administrative Contractors, you're going to want to look at those nuances because, as I mentioned before, Novitas is a little bit different than Noridian, and you might want to look at what their frequently asked questions are, if they have specific links that you can subscribe to. I know that I've subscribed to quite a few where they will update you with COVID updates. They might send you MLN Matters updates from Medicare at a national level, but they also have their own frequently asked questions. And for those of you that are familiar with working with Medicare contractors, they might even have differences in how they will level an exam or calculate a level of exam. And so you just want to make sure with that same level of detail that you're looking at the COVID and telehealth related updates from those payers so that they have the national level, but again, they have their own nuances. So just make sure that you're looking at those. Along those same lines and within those Medicare MACs and or Medicaid payers, you're going to have specific guidance that have different reimbursement methodologies. So rural healthcare clinics have a different payer methodology. FQHCs have a different payer methodology. Tribal Health has its own guide and its own rules, especially if they go through Novitas. And so availing yourself of those jurisdictional type of guides and information that they have to provide is going to be really critical to making sure that you're being compliant with those rules. And then also paying close attention to the place of service that they're asking. So as you're going through and looking at your Medicaid and your Medicare and your specific contracts, you're going to want to look at the different places of service that they want utilized. So Medicare kind of wavered back and forth a little bit, but they have finally come to say that for these telehealth visits, they want you to go ahead and use the same place of service as if it was provided in person. And Medicaid, however, many of them are saying we still want place of service 02. And a lot of the commercial insurances are following Medicaid and requiring the place of service 02 to show that this was provided via telehealth. So again, just make sure that you're subscribing to that and paying attention and keeping up to date, because this could change tomorrow. And then, of course, review any of the specific modifier guidance that the payers have for the telehealth and COVID. There was mention of use of modifiers 95 and CR, and depended upon, there were other ones that were already in place, like GO for telehealth stroke-related visits. And so there were some things that were happening over telehealth already, so there were some modifiers in place, but because those modifiers were there, some payers are utilizing them different. So again, that's just a recommendation that we have, is just to make sure that you're following up. And of course, if you're not aware of what those are, and maybe the payer's website, Blue Cross Blue Shield, Aetna, United Healthcare, maybe they don't have all the information that you need, I would definitely recommend that you call and get a hold of one of their representatives to have them point you in the right direction. They might say we follow Medicare guidelines or something like that, but I would always want to look at, is there anything in writing that says that, or anywhere that you have anything published about frequently asked questions or things like that that are specific to the COVID and telehealth, just to make sure that your billing and coding team are following those guidelines. And so, as I mentioned earlier, the rapid deployment of these telehealth options, a lot of the payers weren't ready to accept claims for the services, so the codes weren't even built into the systems yet. And also at the organizational level as well, some of these codes weren't being utilized because they weren't necessarily a payable service. So, like I said, a phone call to the patient that was, a discussion that was going on was not necessarily a payable service. And there were also new COVID-related codes for the tests that were being created real time. And there wasn't pricing that was established initially. And so a lot of this was happening, and there were claims that were being put on hold until the payers were making decisions. And then once they made the decisions, those claims are still on hold, because now what do we do with these that don't meet the requirements? And there were different place of service instructions. So most organizations may not even had place of service 02 built into their system for those Medicaid claims. And so that takes an IT level support to be able to get that implemented. And again, your claims are on hold for that. And then there were revisions to those instructions that were published that were happening real time. So here you are making all of these changes, and then they revert and say, no, go ahead and just use the place of service where it would have happened had it happened face to face. And so some of those efforts kind of felt a little wasted. And so there were also some decisions being made. Are we even going to bill for the COVID testing? And making sure that we were deploying like a really cohesive education to our providers, because with these instructions changing real time, you might have instructed your providers to document in a certain way, and then all of a sudden something's changing and now we needed to document it in a different way. So that presented quite a few challenges along the way. So I want to go over some of the examples that we found while reviewing some of the documentation as we compare them to those bullet points that I shared earlier from the Washington Medicaid site. And so start and stop times and or total times that were not documented. So there are services that are time-based, like the telephone visit calls, the 99441 through 99443. So as with any time-based code, if that time is not documented, it's not a payable service. So it's a little bit different than an evaluation and management established patient or new patient code, in that there's times associated, but there are key components: history, exam, medical decision-making, or with the new Medicare changes, the medical decision-making and or time. There's options on how to get to a certain level, and you can override things. It might be a fairly straightforward diagnosis, but you spent a lot of time with counseling and coordinating with the patient, so time may become a factor. But there are some codes that are truly time-based. And so if you do not document the time, it becomes a non-billable service. And so we found that there were instances where the total time was not documented, and therefore we're not able to get payment for those. Patient consent has been a little bit hit and miss, where different payers have different ideas on what they want as far as guidelines for the patient consent. For Medicare, they're a little bit more flexible, allowing for the patient consent to be like a consent form that you might already have on file. can be updated to include the telehealth verbiage, and then it can be done after the fact at the next time the patient comes in the door. And so they're basically saying you don't have to hold up the claim. You can go ahead and do that. You can get the verbal consent. I would recommend documenting that you got the verbal consent from the patient to do that as you're having that audio or audio video telehealth encounter. But Medicaid has been, as we're going through and looking at the different states, we're finding a trend that they're being really firm about the requirements for the consent to be documented every time at the time of service. So when you're reaching out to the patient to have that telehealth visit, basically making sure that each time you're saying, you know, we're doing this via this telehealth modality and getting the patient's consent verbally, or having them do an e-signature on a consent form. If it's verbal, recommending that they come in, and the next time they come in, just go ahead and sign a form so that you have it on file. Anything to basically cover yourself that that patient was made aware. Also, the specificity of what telehealth modality is being used and whether or not it is HIPAA compliant or not. So make sure that you're looking at the guidance that is out there on what is considered HIPAA compliant. So Zoom for healthcare is HIPAA compliant. Zoom for your regular office meetings, not HIPAA compliant. And so if you have the opportunity presents where you need to have that visit with the patient, but you may not have the ability to use a HIPAA compliant methodology. So the best practice would be, again, as we talked about, notify that patient that it is necessary that you're going to be using that non-compliant option, and clearly make that very clear in the chart note that they were notified. And again, based off of that Apple Health Medicaid of Washington, they had a little blurb, an example that I found really useful that you can see below, but basically identifying why you're using a non-HIPAA compliant platform, and the fact that you cannot guarantee the security. They will do everything in their power to ensure that their privacy is protected, but they need their verbal consent to go ahead and agree to proceed, and they're willing to take that risk. So I thought that that was a really good example to share that you might be able to build into a template. And so it's so nice I said it twice. The chart note is missing the specific telehealth modality being used. And it wasn't a mistake. The reason why I put it back at the top of the page on this slide is because it's very commonly missed in the documentation. You wouldn't think so, but it is. They might just say that it's happening via telehealth. They're not saying the modality. And so clearly identifying if the visit was audio only, audio visual, it was synchronous, asynchronous, if it was text, if it was email, using Zoom for health, all of those things become a factor when making sure whether it's HIPAA compliant or not, and that can change the billing. Also, we were finding that there are services that were being performed via telehealth that do not stand alone as a billable service. So calling someone to give them their test result. That's a pretty standard thing to do, and it's just that they can't, normally you don't even call the patient back in to do that unless you potentially have some bad news you need to share and want to go over the risks and treatment benefits and things like that, where you would have a face-to-face visit. But again, that can happen via telehealth now. So the other things that are associated with whether or not a telehealth service may or may not be payable is if you are following up with the patient on a visit that happened within the past 7 days and it's related to that visit, or if that telehealth visit prompts another visit or a procedure in the next 24 hours, that's basically going to bundle together. It's not going to be a separately payable item. And then secondarily, there are time-based minimums that need to be met. So let's say for that phone call, if it's less than 5 minutes, that's not going to be a payable service. So just paying attention to what those rules and regulations are. Also making sure that the originating site where the patient is located, whether it's in their home, whether they're in skilled nursing facility, and just making sure that you're documenting that, and then where the location of the provider is not being documented as well, because we do have some providers that are working from home, and or they might be at the hospital outpatient department when they're making their phone calls to their office patients. And so just making sure that they're documenting the location where they're at. And so we also have some recommendations that we feel would help in an organization to kind of stay on track with all of these. So first is to identify a process to verify the patient's identity when you're doing telehealth. You might be seeing a new patient via telehealth. You might have a patient that is established to the practice, but it might be a different family practice doctor that had availability or that is following up. on that patient. So just, you might want to, especially if you have video options, maybe have them show their ID or something along those lines so that you can make sure that you are actually talking with the patient. As you can imagine, anytime these things change, you kind of open yourself up for liability and potentially talking to somebody who presents themselves as a patient and they are not. You want to be able to offer different options and modalities for the patient to use. And so I know that I live in a remote area. And so sometimes if I'm trying to do something over the internet, my connectivity can be an issue. And so potentially maybe have more than one option open to the patient. And what I would also recommend is if you have the ability out on your site, your website, to have a link for people to test their internet speeds to see if they can partake in one of those audiovisual or video telehealth encounters before the visit. Because if that doesn't work, then give them a method to be able to contact you and say, hey, can we use another and something else, because they might not have the speeds to run a Zoom meeting or something along those lines. So just that you're prepared in advance for how you're going to have that conversation with the patient. And then confirming the location of the patient so that it can be, accurately documented in the note. If during that visit the decision is made for that patient that they're going to need to come in, maybe they're showing signs and symptoms, or they have something where they physically need to come in to see if they have a break or a sprain or something along, have a plan in place to say, okay, tell the patient, are you needed to go to the ER or am I going to have you come to the office? If they're going to come into the office, have some instructions about how that's going to happen. Should the patient go into the building to check in and register, or should they wait in the car and call a number to get instructions when they arrive? Can they have family or caregivers with them? Are there mask requirements that are in place that they need to follow? If they don't have a mask, are you providing masks for them? Some organizations are going cash-free during the COVID crisis, and so if you have that policy in place, you want to make sure that you're providing those instructions and giving those revised payment options. Maybe you want to offer payment on your portal or those types of things to be able to accommodate that cashless methodology. And then also, as we talked about those bulleted items above, make sure you're setting up a template to ensure that you're capturing all of those documentation requirements, being the most conservative, capturing all of that data every time. It doesn't make you bulletproof because there could be payers that have a little bit different requirements, but those are a pretty good baseline to start from that should cover you for most instances. And then again, from a billing and coding standpoint, one of the struggles that we're having is to have a plan in place to identify how are you going to reconcile those visits that after the fact, and when you look at all of those bullets, oh, we weren't documenting that modality, or we didn't have the right patient consent in place. You're going to want to make sure that you're going to have to resolve those out of your coding and billing queues at some point. So whether or not they're reimbursable or payable, do you want to create a dummy code so that you can track them or track those losses? It might not even have been a billable service. So do you even want to count that as something that should have been a loss because it didn't meet the requirements? And so I would have a conversation with your HIM and revenue cycle teams, as well as your organizational leadership, to say, how do we want to address these visits that are happening that are potentially non-payable, but yet we do need to reconcile. We don't want to increase our DNFB and DNFC with encounters that aren't going to generate reimbursement. So that being said, I did include the links to some of the information that we shared above, mostly focusing on Washington Medicaid because, again, they had the strictest guidelines that I could find, and then also guidance from CMS that is published nationally. And so as I say goodbye, I wanted to also share this last slide where our executive director of our CBO team, Cassie Wise, is going to be having a presentation on August 5th, and I'm excited to watch it. So thank you very much for your time, everybody.
Thanks, Teresa. You did a great job. We will be sharing, as usual, everybody will be sharing the webinar recording and slides in an email later this afternoon. Including in that email is a link to a survey. We would so appreciate you letting us know your thoughts. We've taken a lot of your guys' recommendations and actually incorporated them into presentations. And as we plan for upcoming weeks, it's certainly helpful in knowing what you guys want to see. In addition, when you guys complete that survey, you can request a certificate of attendance. Those will be sent out later this week. And once you complete the survey, you'll be entered to win a $25 Amazon gift card. As Teresa mentioned, next week we'll have HRG Executive Director of CBO Services, Cassie Wise, joining us to discuss AR changes in this current climate. She'll cover how to keep your AR stable when revenue is just not. Thank you all again for joining us. We look forward to being back with you next week for another webinar Wednesday. Have a great rest of your day.